right, like he said, he was saving the best for last. All right, so do we have a... Is it just the green? Yeah, all right. I'm Julia Kenniston. I am the hand surgeon. So this is my background. It's my 10-year anniversary. I've been with these guys for about 10 years now. So, yeah. And I plan on dying here too. So you're going to see me around for a long time. I'm board certified in orthopedics and hand surgery. My hand fellowship was at Brown, and I was at Penn for residency. For my MD, I went to Tufts, and then for my undergrad degree, I actually went to University of Chicago because I'm a Midwesterner. Anyway, so we're going to talk about injuries in the hand and wrist. So I say weekend warrior, but it's really anyone. These injuries, they can happen in sports, they can happen not in sports, they can happen anytime. So the injuries, I'm going to kind of split them up. I'm not going to talk too much about overuse injuries or tendinitis, but I'll kind of touch on it. But mostly I'll talk about trauma, and that's going to split into like fractures and sprains. So starting at the fingertips, we're going to start with mallet fingers and jammed fingers, skier's thumb, and then a couple different types of fractures in the wrist, and then just a brief blurb on tendinitis. So those of you that know me in the office in the OR know that I kind of go fast. So some people say quick, I say efficient. So we're going to go through this really efficiently. So anytime you have a trauma in any extremity, hand, foot, ankle, knee, whatever, the usual things first apply. So rest, ice, compression with an ACE wrap or splint the extremity, elevate to help with swelling, and then of course anti-inflammatories if you can tolerate them, or Tylenol, and x-rays if you need them. So starting with the tip of the finger, we're going to go with the mallet finger. So the mallet finger affects the distal part of the joint here. So a lot of times this is kind of a jamming injury to the distal part of the finger. Most people actually don't know what they actually do when they get a mallet finger. Some people have the obvious trauma, a ball hits their finger. I do have a string of patients that injure their finger making their bed. So a lot of mallet fingers for making the bed, so possibly we should stop doing that. And then the jammed finger, is going to be this middle joint here, so the proximal interphalangeal joint. So these are typically ball sports, basketball, volleyball, things like that. And what happens is the finger will hyperextend. So this results in a sprain of the joint, and sometimes it actually results in a little fracture too. So starting with the mallet finger, this is the droopy finger that you see. So the reason why it droops is The reason why it droops is because the tendon that inserts at the end has pulled off the bone there. And so it isn't able to lift that finger up. But the tendon on the other side that bends the finger down is still active, so it pulls the finger down into flexion. So with the mallet finger, you aren't able to extend that distal joint. There's usually swelling and a little pain in that area. So when that tendon pulls off that bone, sometimes it actually pulls a piece of that bone off too. In terms of treatment for the mallet finger, so there's non-operative treatment and surgical treatment. For non-operative treatment, it's really these splints. So the hand therapist will make whatever type of splint works best to hold that finger in extension. It's really important to keep that joint fully extended constantly, because if it is allowed to bend, it just keeps stretching that tendon out. So you want to always either keep it in the splint or somehow protect it so that joint's extended, because that flexor tendon on the other side is always going to keep pulling it down. With these splints, you can see they stop at the PIP joint, because you do want to keep those joints moving. If you don't keep those PIP joints moving, everything gets really stiff in that joint, and it's hard to get that motion back. So we try to keep that joint moving. Skin checks are really important, because with that pressure of the splint, it can macerate the skin at that dorsal DIP joint. So some of the studies have shown really good outcomes with non-operative management. So if you can be compliant with the splint, your outcome will be very good. And what they found is about a 7.6 degree extensor lag in patients who have just treatment with the splint. So the splints are great options for it. The other option is surgery. So with surgery, it's more of an internal splint. So what we do is we actually kind of drill a metal pin in through the joint. So this little wire goes across the joint here to keep that joint in extension. So it's really an internal splint. So this is for the absolute indications really if there's a really large fracture there or if the DIP joint is subluxating volarly because of that flexor tendon, then we do have to pin it. But for a lot of people, it's just personal choice. They can't tolerate the splint. They don't think they'll be compliant with the splint. Personally, I would probably pin my finger if I had a mallet finger because then I could keep operating. I can't operate in a splint, but I can operate with a buried pin. So outcomes from pinning is a little bit better than splinting, just a couple degrees, but overall they're pretty equivalent. The problem with the pinning, though, is that there is increased complications. So possibility of nail deformity when you're drilling the pin in, if you kind of scrape their nail bed, you could get a nail deformity, and of course infection with any surgery. And then if you see these mallet injuries as a chronic injury, if they've had it for a really long time, there's really no way to effectively fix that, and so most patients do better with just an arthrodesis or a fusion of that joint. So the jammed finger is that hyperextension in that proximal interphalangeal joint. So what happens is the finger kind of bends back and hyperextends, and it puts a lot of strain through all the ligaments, the joint capsule, and especially this kind of thick plate here called the volar plate at that PIP joint. So things to do with those PIP sprains. The usual things, rest, ice, anti-inflammatories. You do want to check the motion because if the fingers go in a different direction, crossing over, it's a good indication that you don't have just a jammed finger or a sprain. It's probably a fracture that's there. So x-rays are helpful. So initially with these injuries, you can splint it for the first week, and that can help kind of decrease some of the pain. You can buddy strap the fingers as well. But it's really important to come out of the splint pretty quickly because you do, like I said before, that PIP joint gets stiff really quickly. So if you don't have to splint it, we try not to. You want to try to get it moving as soon as you can. So usually I tell patients, if you want to splint it for a week, that's fine, but after that week, you have to get it moving because that's the main goal is to get the motion back. Skier thumb. So this is called skier thumb because first we saw it in these guys. They would fall with their ski pole in their hand, causes this hyper abduction and extension on the thumb. So what you injure is this, on this side, there's a ligament on the inside of the thumb there, and that's really important to stabilize that thumb MCP joint. It's really important for pinch and grip activities. So you need to have that to be intact. So with kind of going on the same line that Dr. Beck went, we'll talk about baseball players. So the most common injury from sliding into base is injuring that thumb UCL. Here, this Verdugo sliding into third on Monday when he was safe. He was not out, bad call, so he was safe. But what I think is great is, so if you look here, see this huge oven mitt he has? This is a great story. So 2003, there was a player on the Kansas City Royals who had this injury. He slid into base, and he had a thumb injury. So first, what he tried to do is once he recovered from the surgery, he had a splint. So he had a thumb splint that he wore, and 5 years later, he slid into base with his thumb splint and broke his pinky. So then him and a hand therapist got together, and they came up with like a more protective mitt. So now, if you keep watching the playoffs, you'll see more and more guys wearing these mitts to protect their hands. So I think it's pretty cool. So when you have a skier's thumb, the first thing is to check the stability of that thumb joint. So the stability is checked in full extension as well as 30 degrees of flexion. And so the most specific test is that 30 degrees of flexion. And so if there's a lot of instability in that joint when you try to stress that ligament, it's a good indication that there's probably a complete tear there. X-rays are helpful to see if there's a bony fragment and also to see the congruency of the joint. But in terms of the kind of levels of injury through there, so it can be a sprain, partial tear, complete tear, or a Steiner lesion. And so a Steiner lesion is when that ligament pulls away from the bone far enough that it actually pulls into what we call the adductor aponeurosis, which is part of a muscle within that first web space. So that's a more severe injury. But basically, the complete tears and Steiner lesions do need surgery. So treatment for the sprains, partial tears is going to be a thumb spica cast, and typically I cast these patients for about 6 weeks. In terms of surgery, you need to repair that ligament back up to the base of the proximal phalanx, because that's where it typically pulls off of right that area there. So I usually use a bone anchor and pull that ligament back up. Baseball players do great from this. They're able to return to play within a few months, and they usually get back to 100% of their usual level. So fractures in the hand of the wrist. I'm really going to cover two types of fractures. One is the hook of the hamate fracture, and the other is the distal radius fracture. So hook of the hamate fractures, usually you see it with club sports. And so in this area, we see it more with golfers, but in baseball players, we see it from playing baseball. Wrist fractures, you see everywhere, any season. People just like to break their wrists. So hook of the hamate fracture. So with golfing, what happens is usually when they're holding the club and they swing, if they hit the ground, the root, something hard, then that end of the club can hit that hook of the hamate. So with baseball, what they blame it on is this nub here. And so with baseball players, it doesn't have to be a bad hit. It can be any hit. And it just happens to break that hook of the hamate. But the pain is going to be kind of in that proximal volar ulnar palm. But, the exam, or basically diagnosis is based on the exam. And then x-rays are sometimes helpful, but you need a specific view, and CT scans are very sensitive for this. So here again, so pain in that volar ulnar palm here. So the CT, or the x-ray view, is going to be a carpal tunnel view. So it's kind of this hyperextended view where they shoot right down. And you can see, you can see this little fracture right through here. But the CT scan is better for looking at it because you can see it here. CT scans are three-dimensional, it's a way to see three-dimensionally of the bone rather than the x-rays, which is just a two-dimensional view. So treatment for hook, MLB players. So this is a partial list of the past 20 years of MLB players that have broken their hook of hamate. So some of the names you'll recognize: Bobby D, Garcia Parra, David Ortiz, Justin Pedroia. So it's a very common injury. At some point, I assume that they'll be changing the bat. So treatment for hook of the hamate. For acute injuries, typically we cast these patients. If it's a chronic non-union of that hook, then really the treatment is to take it out. We don't fix the hook of the hamate. So in the past, they've tried to do different types of screw fixation for this, and it just doesn't work out. So it's either cast to get it to heal or excision. So for chronic ones, we do excise it. Now, baseball players have it excised immediately because it's the quickest way to get them back to play. So they take it out, and what they found is they're able to get back to doing everything they want to do within a couple of months, and it doesn't seem to affect their play at all. So distal radius fractures. This you see all the time, or I see all the time. It's the second most commonly fractured bone in the elderly. Almost 20% of the elderly do have wrist fractures, and it's the most common, fracture seen in older white women. But basically, when you fall, outstretched arm, if there's swelling, pain, deformity in there, the usual things first: rest, ice, anti-inflammatories, splint, and x-rays. So anytime there's a deformity after a fall, you do want to x-ray that part and see what's broken. So the treatment for wrist fractures is really based, on kind of these factors. We want to try to decrease pain, preserve hand and wrist function, avoid any type of complication, restore the anatomy when necessary and appropriate. So the options really are cast and surgery. So not every wrist fracture needs surgery, and it's really patient-specific in terms of who does need surgery. But certainly young active or even old active do need surgery, but not everyone does. So we base it on fracture pattern, age, hand dominance, work, hobbies. For instance, this woman probably needs her wrist fixed, but some of her friends probably don't. So tendinitis. So this is going to be your overuse type of injury. And these are, people that are sedentary all week, and on the weekend they start doing a lot more activities. Especially in the spring and fall is when I see more cases of tendinitis. And this is because of, I think, yard work. So in the spring and in the fall, more people are doing a lot more yard work, and so they start, doing these overuse injuries to their tendons. Sometimes trauma can cause it, and sometimes it's just your basic anatomy. Symptoms from tendinitis are going to be pain, swelling, crepitus, which means kind of a popping sensation when you start moving certain things because it's the tendons popping against each other. So Treatment for tendinitis, again, same thing. So rest, anti-inflammatories, stop doing the thing that's causing it, or at least stop doing as much of it. Try to temper how much you're doing with it. Temporary splinting, I think, is okay, just short term. I don't think it's a good idea to do long-term splinting for tendinitis because it just makes everything a little weaker. Stretching and strengthening is really important for tendinitis. Hand therapy is very helpful for tendinitis if the other things aren't helping. For some types of tendinitis, you can always consider cortisone injections, and for some types of tendinitis, there's always some surgeries too. But most tendinitis are not treated with cortisone or surgery, and they do get better on their own. So, thank you.